Moving towards our next session, metformin drug has been shown to prevent diabetes as the initial drug of choice. But now, is there any possibility or evidence that it is losing its pole position? To guide us about this, we have two eminent speakers with us. Dr. Kaushik Biswas, an eminent endocrinologist practicing more than 20 years, who will be talking about in favor of metformin drug. And the another one, Dr. Anirban Sinha, another renowned endocrinologist attached to Medical College and Hospital. He will be talking about SGLT2 inhibitor. And to moderate this session, I would like to invite Dr. Rahul Bhattacharya, consultant physician and diabetologist attached to Bhagirathi Neotia Hospital, and Dr. Shoibal Chakraborty, consultant physician and diabetologist attached to GT Hospital. Dr. Rahul Bhattacharya. And Dr. Shoibal Chakraborty. Is there any possibility or evidence that it is losing its pole position? To guide us about this, we have two eminent speakers with us. Dr. Kaushik Biswas, an eminent endocrinologist practicing more than 20 years, who will be talking about in favor of metformin drug. And the another one, Dr. Anirban Sinha, another renowned endocrinologist attached to Medical College and Hospital. He will be talking about SGLT2 inhibitor. And to moderate this session, I would like to invite Dr. Rahul Bhattacharya, consultant physician and diabetologist attached to Bhagirathi Neotia Hospital, and Dr. Shoibal Chakraborty, consultant physician and diabetologist attached to GT Hospital. Dr. Rahul Bhattacharya. And Dr. Shoibal Chakraborty.
Session. This will be on metformin. It's interesting to note that even after 100 years, and when metformin is practically an orphan molecule, you'll be glad to know that almost 12,000 articles have been published in last 10 years on metformin in index journals. So now we have two eminent speakers, two endocrinologists who will talk on metformin. The topic is metformin losing its pole position in the management of type 2 diabetes? Let me invite Dr. Kaushik Biswas first.
See, there has been some confusion. Both our speakers are basically prepared for the motion. Okay. So what I am doing is that let one person speak the slides and the other person basically is in the chair, so he will perhaps comment for or against, doesn't matter. Yeah. Okay. Thank you.
So anyway, so we are actually supposed to debating on the metformin controversy. So okay, so anyway, I'll be talking in subsequent few minutes about the relative positioning of metformin in the management of type 2 diabetes mellitus. Let me begin with a little trivia that this bridge, the famous bridge, is situated in Greece, which was founded in Bronze Age, and it is still passable by the population. On the other hand, in sharp contrast, we can see what happened just 1 month back in our neighboring state for the second time. My point is, even one thing is old, if it is based on, if its scientific foundation is very strong, its integrity is very strong, then we should ponder to continue that molecule or that thing. If we consider the history of journey of metformin, it's tremendous and a triumphant one. In 1772, the extract of Gallica officinalis was supposed to be used as a treatment of polyuria. And then the drug was rediscovered again in 1950, and Dr. John Stern in France introduced as an anti-diabetic agent for the first time. In subsequent 2 decades, there was extensive study as well as uses of metformin in the Europe. But it is only 1994 when it was approved by FDA, and only in 2010, WHO enlisted metformin as the essential medications. So this long, tremendous journey itself stands for the molecule's first position in the management of diabetes mellitus. It has basically nothing to prove. Why it should be there in the first position? Because it is effective, safe, globally available. There is ample amount of cardiovascular safety data, and it is weight neutral, and most importantly, it can be partnered with almost all available anti-diabetic agents. It's very cheap, and it is the father of non-glycemic benefits. If we consider the Eukipedias trial, we know that in the obese individuals, around 736 individuals were randomized to either metformin or standard of care. And at the end of 10 years, there was significant reduction of any diabetes-related endpoints, all-cause mortality, and myocardial infarction. And we can see the metformin-related legacy effect after 44 years of first randomization of Eukipedias, how beautifully there is any diabetes-related endpoint, myocardial infarction, or all-cause mortality, but still continued to be low in the metformin arm in obese individuals. So there are many other studies to show the cardiovascular superiority of metformin. I'm not going into detail. We often are afraid of using these molecules in special populations like chronic liver disease, CKD, and chronic heart failure. But what studies said, this systematic review is particularly saying that uses of metformin in moderate congestive heart failure, CKD, and chronic liver disease is associated with actually improvement of all-cause mortality. So why should we fear? And another thing, the so-called blockbuster molecules like GLP-1 receptor analog or SGLT2 inhibitors related studies done in the past 1 decade, at almost 70% of cases, those patients were already on metformin therapy. And if you divide those population into metformin users versus metformin non-users, you will see that there will be heterogeneity in the findings. So metformin in the background is playing some role. We don't know whether it is bad or good, but it is doing something in the background of those blockbuster molecules. Now, as I've mentioned before, metformin is the Prince Charming of pleiotropic effects. We are fascinated by the pleiotrophism of the blockbuster molecules like SGLT2 inhibitors or GLP-1 receptor analogs, but metformin, we can see that it reduces blood glucose, it reduces hyperinsulinemia, it decreases LDL cholesterol, increases HDL, it decreases free fatty acid levels, it increases GLP-1 receptor, GLP-1 levels, as well as the responsiveness of GLP towards its receptor. It reduces oxidative stress and pro-inflammatory markers are diminished with metformin therapy. Clinically, it reduces blood pressure. Well, it is weight neutral, but we have seen that it actually reduces weight in many cases, and it provides some neuroprotections. I have shown that it is protective towards heart. Not only that, probably it has some anti-cancer role, and it may be associated with aging. I'll discuss later, and we use it in other conditions like polycystic ovary syndrome. In COVID-19, there is a study to show that who are treated with metformin previously are supposed to have less severe COVID-19 infections. So, observational meta-analysis had shown that metformin users are associated with lesser incidence of several cancers, including breast, colon, lung, prostate, and liver cancers. Though we do not know whether metformin is going to be used as an anti-cancer drug, but this is an important observational findings. And still, a very few dedicated scientists still believe, and they are working on it, that metformin can have some anti-aging property, because it has been shown in subclinical study to prolong the longevity of organisms like C. elegans. I'm not going into detail. Metformin has been shown to be associated with slowing of progression or accumulation of age-related comorbid conditions in type 2 diabetes mellitus in elderly populations. It's a very safe molecules. And long-term use of metformin is associated with reduced risk of cognitive function as well as improvement in small vessel vascular disease. So nowadays, becoming a doctor is becoming day by day very riskier from both non-medical and medical reasons. And at least for medical reasons, we should consider the good effects of a drug as well as the side effects like genitourinary tract infections, euglycemic decay, amputation, fracture, volume depletion, and acute kidney injury. Otherwise, we may become the overly romantic Ronald who fell down from the boat and sank down. So let's see about some data regarding the positioning of this molecule. One of the beautiful study, multi-center study, retrospective study, database study, assessing the sodium glucose transport SGLT2 inhibitors versus metformin as the first-line therapy in patients with type 2 diabetes mellitus. We can see that in the end of the study, there was significant improvement in terms of heart failure hospitalization, acute coronary syndrome, and all-cause mortality with SGLT2 inhibitors in comparison to metformin. So all very good results, but there is a but. There is a increased incidence of ischemic stroke in patients, those who are treated with SGLT2 inhibitors in comparison to metformin. So everything has to be taken into with a pinch of salt. Now, recently, a comment has been made by Dr. Daniel D. Dressler while reviewing a paper on cost-effective benefit of SGLT2 inhibitors and GLP-1 receptor analog. He said that they would not be cost-effective on current US prices. The first-line SGLT2 inhibitor and GLP-1 receptor analogs were associated with only 5% fewer macrovascular complications compared to first-line metformin. And most importantly, these newer agents increased life expectancy by only 3 months. So it's a very recent study. Another small study, but it's a poster basically, not peer-reviewed yet, assessing the real-world effectiveness of SGLT2 inhibitors versus metformin as first-line therapy in type 2 diabetes mellitus. In that study, they have taken all comers, first time exposed to either SGLT2 inhibitors or metformin, and they assessed them for 5 years. And what they found, this is the result. The hazard ratio of the cardiovascular outcomes as a whole, or even the individual component like ischemic stroke, myocardial infarction, hospitalization for heart failure, were not favoring SGLT2 inhibitor in comparison to metformin. On the other hand, not only that, there's a, in SGLT2 inhibitors group, there was less chance of having HbA1c less than 7% within 1 year. So I want to conclude by giving these three important messages. Like love, that means sharing the long winter nights together. Metformin is there since last 50 years. So there is no question of divorce between metformin and physicians. And probably there could be some makeup, like hair dyeing like thing, but there will be no question of divorce. So the second picture, as our house, the most important part is the foundation. Foundation should be very strong. The foundation should be metformin, upon which we can build the hanging garden of Babylon with GLP-1 receptor analog or SGLT2 inhibitors. There is no problem. Most importantly, in the third picture, like in contrast to the Plato, who is directing to the realm of Ache and Nei, the realm of surrealism, we should follow his disciple Plato, who is saying, Aristotle, who is saying, stay calm, remain grounded, and follow the practical situation. Thank you.
So, thank you. Keep that picture. Keep that picture. Last one. Yeah, thank you. So, we have heard so many historical landmarks, and we have learned a bit of history of medicine in this previous talk. My dear friend Kaushik has tremendously given an enormous experience of what history tells you. Right. What is the slide there? It should be there. I don't see it here. Yeah, but we should remember, we move on again beyond what history tells us, because we are not in the Napoleon age or maybe in the age of Hitler's. They were all wonderful age as their times, but when we look back, we do not see that maybe the ideal most time in our history of maybe the Indian culture or maybe the European history. So even the Mughal history has their benefits and their pitfalls as well. So not always the history is very good in their remembering them. So you should remember, we should go beyond history and go live in the present time, because maybe we should survive on the Sharpagandha trees if we had been not going for a recent medicines also. So if you go back history, why do evolve to the modern medicine? Stay back in the history and keep on using Sharpagandha, Desarpins and Kalmeg and those nice things which we used to use, Charak and Shustruto days. So you should evolve yourself to learn, and learning and unlearning things is the most beautiful part of science. So there lies the beauty of science. Staying back to the old thing is more of a rigidity in my understanding. So we should evolve and learn things and expect that when the data and studies available. Definitely there are studies in favor of metformin. I'm not fighting to keep the metformin out of the first position. What I want to say is that metformin and other drugs have equal benefits and can be given in the first line. It is not the only drug which should be given in the first line. Now coming back to the pictures. So staying one night together may not be a good thing to live in the life. So remember the slide. So it is not the way of surviving. It has to be living for your lifelong. So that picture reminds you it should not be the one thing you should be doing. And you see the second picture. So there is a huge basement. So how can you climb up the basement to reach the house? So again, making a house which is unrealistically huge basement, or maybe the stone which you make it on, it makes it more robust, but it is unrealistic to live in, because you have to climb up so many stairs. So you have to be realistic to live in a natural way where it is acceptable and moderable. And you can use it in a regular life. So it cannot be an unrealistic basement or stone where you can make a house. Third point, again, as I said, we are not in the age of Plato's. Again, Plato and Aristotle were wonderful philosophers. I'm not denying that. But all the teaching in Plato and Aristotle were still not applicable, and they were in the utopian era. You remember that is the classic age of utopia. So it is not in the reality. So we do not accept all the things which is supposed to be. So it should be more realistic and evidence-based. what the data available in our clinical hands. So that data definitely show us, even the guidelines, what you look at the recent 2023 guidelines, we see that even the patients with known cardiovascular risk, it has been recommended in the guidelines that you can use the GLP-1 agonist or the SGLT inhibitor as a very first line. And definitely that has been recommended and used worldwide. And are they fools who made the guidelines? I understand that can be influences from the different houses, but definitely they are not fool enough to prove them wrong if they don't have the adequate evidence to put that. So if most of the patients in our diabetic actually having the significant cardiovascular disease risk, so if the patient who has a significant cardiovascular disease risk or the ASCVD score, if done, I'm not leaving behind the pitfalls of ASCVD risk. So most of the patients are moderate to severe cardiovascular risk when you see a patient in a clinic, if you can have the time to do that. So then maybe if you can choose a drug which has a solid evidence to give the solid, robust treatment and preventing the outcome of the cardiovascular disease, where the metformin, definitely good one, but it has a weaker evidence to actually counteract the cardiovascular disease when the patient has a significant ASCVD score. Did we ever talk about, before the SGLT2 or GLP-1 agonist era, that metformin should be given for cardioprotective action? Did we ever talk about that in the last 10 years, before the SGLT2 and this thing come? Never. So this is a weaker and corollary done to show that, again, metformin is also good. So it is just an also added there. So it is not that it should be given. It's a superiority trials actually there for the SGLT2 and GLP-1 agonists, which are good for outcome. And again, thirdly is that pleiotropic actions he was talking about. Definitely metformin has many wonders to show again. We'll keep on learning about metformin. But again, the other drugs we talk about, like the SGLT2 inhibitors or the GLP-1 agonist, they have many more additional pleiotropic benefit. They have benefits in the heart, benefits in the brain as well. Again, metformin may have that, but it is yet to be proven. So the drugs with a known positive pleiotropic effect beyond metformin, and nowadays we are learning that metabolic disease or diabetes is a heterotropic disease affecting multiple organs simultaneously. It is not the insulin resistance or the insulin secretion failure. So if the drug can address multiple actions of the disease or the multiple disorders of the disease together, that can be chosen first for the treatment of the diabetes, where multiple comorbidities can be covered together. So these drugs maybe have best benefits. And as I said, the guidelines are rightly made in the path. And again, there are Indian guidelines, I remember, where the sulfonylurea has been talked as a first-line drug replacing the metformin also, because they are cheap. If you talk about cheap or the cost effectiveness, sulfonylurea is as cheap as metformin, and they are as good as controlling glycemia. So the most important thing as a clinician, we see that controlling glycemia in the diabetic patient is the most effective thing to get a good outcome of the patient, be it a cardiovascular event, be it other complications. So if you have a poor glycemia and patient keep on having the metformin, you cannot prevent the complications of the disease, like the foot ulcer, like the neuropathy, nephropathy. You cannot prevent that. So you have to get a good glycemic control. For that, maybe sulfonylurea has been considered in Indian guidelines also for the first line, along in replacement of metformin. Either metformin or sulfonylurea can be. I'm not saying do not give metformin, but it as good as metformin in the beginning. And same is the international guidelines nowadays talk about the GLP-1 agonist and SGLT2 inhibitors, because they are as good as reducing HbA1c reduction, almost one, if we started in the fresh or the first drug given. So they are as good as metformin. And coming to the maybe the last point as the cost. So with the loss of patent and Indian scenarios, nowadays GLP-1 agonist, barring the GLP-1 agonist, other drugs like the SGLT inhibitors or the DPP-4 inhibitors, they are almost as cheap as sulfonylureas, if not metformin. Metformin may be the cheapest one, I accept that. But they are not very significantly different from the generic SGLT inhibitor or the GLP-1 agonist. So cost nowadays is not a concern, and with this shining India, we are per capita income may have been increased, and our patients, though they bear it from their pockets, and even the government hospitals like us, I am in medical college working as a professor, so they also provide the SGLT inhibitors and DPP-4 inhibitors in the government supply free of cost to the patient. So cost remains neutral in this situation. So you cannot talk about cost and do not give the best treatment to the patient. So that is another way of looking at. So in the end, maybe I talk about there are very good students I've seen in my MBBS career who have actually read only the book's fine prints and try to impress the teacher in the exam or viva. So that is one category. This is almost like talking about the fine prints of metformin and glorify it. Definitely it is a good drug, but glorifying it with the fine prints does not make it a practical sense. That is my rebuttal maybe. Thank you very much.
So now you have heard arguments, wonderful arguments from both sides. And before you make up your mind, let me ask Dr. Kaushik Biswas if he is interested in rebuttal. Dr. Kaushik has already given you some idea about goat's rue. ছাগলের দুধ বানানোর জন্যে কান্ট্রি সাইডে একটা ঝোপ পড়ে থাকতো সেইটা দ্যাট ওয়াজ ভেরি টক্সিক অ্যাকচুয়ালি সেইখানে তার মধ্যে গ্যালিজিন আর গুয়ানিডিন পরে পাওয়া গেল ইটস অলমোস্ট 100 ইয়ার্স গুয়ানিডিন ফার্স্ট সিনথেটিক ডেরিভেটিভ 1922 নেক্সট 20 বছর শুধু জাস্ট বিকজ অফ ইনসুলিন পুরো শোটা ক্যাপচার করে নিল বাকি সবাই ব্যাকসিট ফার্স্ট ওয়ার্ল্ড ওয়ার UK scientists, they were desperately looking for a molecule which can treat fevers, malaria. কেন জাভা সুমাত্রা এইসব জায়গায় সিনকোনার চাষ হতো কুইনাইন হতো সেখান থেকে পুরো সাপ্লাইটা আসতো ওরা টার্মস ডিকটেট করছে আমাদের অন্য কিছু চাই ওদের ওপর ডিপেন্ডেন্ট থাকবো না ওইখান থেকে তারা পেলো তারপর একজন ফিলিপিনো ফিজিশিয়ান সে ফ্লুমামাইন বলে একটা এই গুয়ানিডিন ডেরিভেটিভগুলো দিয়ে দেখা যেত জ্বর সেরে যাচ্ছে প্লেগে ইউজ হতো স্নেক বাইটে ইউজ হতো অ্যান্ড মেনি অফ দেম অ্যাকচুয়ালি ডায়েড বিকজ অফ দোজ থেরাপি দোজ র থেরাপি ওই সমস্ত জিনিসগুলো অ্যান্ড তারপরে ওই যে যা স্টার্নেরটা দেখালো সেই স্টার্ন অনেক পরে 30-40 বছর আগে তার 30-40 বছর আগে পোল্যান্ডের দুজন সায়েন্টিস্ট তারা এটা সমস্ত কিন্তু তারা পুরোটাই অ্যানিমাল এক্সপেরিমেন্ট ছিল হিউম্যানের ওপর ইট ওয়াজ নট considered fit for use. Dr. Sinha is not interested. History diye cholbe na. So he told you about the latest evidence-based medicine. UKPDS 342 patient data, vis-a-vis 35,000 plus data, CVOTs. So now Kaushik is getting another chance.
So first of all, thank you Anivanda for wonderful counter, or I should rather say encounter. I just made few points. I'll just first of all, the analogy of sulfonylurea and metformin I do not think very good. We're not talking today, not talking about only glycemic control. That's why the debate is on. So sulfonylurea does not have any significant non-glycemic benefits like metformin. So this is the single most point. We are not talking about the glycemic lowering capacity. We are talking about the non-glycemic benefit. So that's why the debate. Who will take the position? Number one. Number two, my problem is I do not want to accept that the SGLT2 inhibitor or GLP-1 receptor analogs are the panacea for all maladies in type 2 diabetes mellitus. Doesn't mean using GLP-1 receptor analog or SGLT2 inhibitors means we will not treat another conditions. We do not need to treat hypertension, dyslipidemia or other comorbid conditions. We also need to optimize those things. But the way those drugs nowadays have been promoted is I think it's quite unscientific. Yes, of course, they are very good drug. Many years later, we have found something beyond certain AC inhibitor or ARBs, which can prevent or delay the progression of nephropathy, SGLT2 inhibitors. Of course, we praise that, but it does not necessarily means we'll demean agent, very cheap agent, which has proven safety and efficacy on those conditions. Like if you have a patient requires good glycemic control, the HbA1c is 10%. Now giving only SGLT2 inhibitors, which efficacy is much lower than metformin, especially in the context of GFR when it is below 50, then is it that amount of glycemia is controllable by giving that molecule? No. GLP-1 receptor analog can decrease HbA1c by 1% or 1.5% depending on the baseline HbA1c level. But we should here we should go by, if we go by the guideline, the ADA statement is that we should personalize the management. Of course, we should personalize the management. If there is established ASCVD, established risk factors like heart failure or chronic kidney disease or multiple risk factors, we always endorse independent of HbA1c level or glycemic parameters, uses of SGLT2 inhibitors or GLP-1 receptor analogs. But we should not forget metformin in these cases also. We should not be carried away by the EASD guideline only, or European Society of Diabetes or European Society of Cardiology guideline only. Because giving SGLT2 inhibitors or GLP-1 receptor analog might be protective against heart failure or development of atherosclerotic vascular disease. Recently, flow study of semaglutide has been stopped because of good result. It has found to have better nephroprotection. But that does not mean demeaning a age-old, very cheap, old molecule with very safety profile, which can reduce HbA1c up to 1.5% with the cost of 1 rupee, 1 or 2 rupees. So that is my whole area of point of discussion. Thank you.
So Dr. Sinha wants to say something in response to Kaushik's rebuttal. Let's hear from him.
Thank you. Everyone gets a chance of counter rebuttal. So just to remind you, the topic was it's metformin losing its pole position in management of diabetes, not the glycemic control. So again, sulfonylurea, as I said, is a very good point for glycemic control and diabetes as well. So sulfonylurea is a very cheap molecule, as is metformin, and it gives you a good glycemic control. It may not have the extra glycemic benefit, though there are some talks and minor, again, the fine prints as we talk about. And secondly, the biggest statement was that guidelines he himself accepted, that most of the guidelines say that nephropathy and CKD requires a special attention, and our patients, if you look for almost 30 to 40% patient are CVD and 30 to 40% patient are underlying nephropathy in the diabetic patient when they present to you. So again, almost 40% or maybe 50% of the population, when you see it, they are actually a candidate for either the SGLT2 inhibitor or GLP-1 agonist. And last point he said, as I mentioned before, that even the government supplies are there, which is free of cost on SGLT2 inhibitor and DP4 inhibitors. So you cannot talk about cost. And again, the availability of the generics in our country makes it almost as cheap. I'm not saying as cheap as metformin. It may not be 2 rupees, but it can be within 3 or 5 rupees. Maybe a 2 rupees difference between these two good molecules, and which has added multiple benefits. So it is up to you to choose which you want to give 2 rupees extra with multiple benefits with proven data, and or maybe you just stay back with only the old one, which has most benefit maybe and age-old benefits, but still other benefits are in the fine prints and is still to be proven in the bigger studies. Thank you very much.
So let me check from you, what is your take on this? Is metformin losing its pole position in management of diabetes? You have heard arguments from both sides. Now, what is your decision? By show of hands?
I think that we should use a combination. Now that we have heard a lot about that step care has given way to combination drugs, but it should not be without metformin. That is my opinion. Metformin should be there, plus either SGL2 or DPP. 2 drugs maybe should be given.
The DPP4 and also the SGLT2 and other, they are adding metformin. Why?
So you are not interested in the fight? Let us use both of these molecules. Fine. Okay. Thank you to have done. So Dr. Shah. Dr. Shah.
মুক্তদা লয়্যালটি সম্পর্কে বলছে হ্যাঁ এত বছর সার্ভ করলো বলে হ্যাঁ হ্যাঁ এরকম করলে কি করে আই থিঙ্ক I'm sure some people may agree or disagree. Metformin has done its job very well. Okay, but I think, as Anirvan said, life moves on, science moves on, and then there are new molecules, new chemicals which seem to perhaps provide an extra edge in terms. And that is what has been recognized by not an individual doctor, but by groups like the European Society for Cardiology, or even say for the nephrology, KDIGO as well, where they have perhaps pipped metformin and put SGLT2 inhibitors ahead. So it is losing its pole position, I would say, but still it's number one. You may think that you perhaps a few notches down. It's like Shah Rukh Khan, perhaps, maybe the last couple of films have not been a great hit, but he still remains a superstar, aisa hai. So that's perhaps where metformin is. We all will continue to use it maybe, okay, and still is perhaps pole position, but it's perhaps losing some ground, that's how I would say.
Anyone else? Hey, Mike.
Metformin with other drugs, they are complementary, not competitive. So for debate's sake, it's okay. But otherwise, metformin should be used as a first-line drug. And as already told that in one Korean study, metformin was withdrawn when eGFR was 60 to 30. And those patients who were in whom metformin was withdrawn, their renal function decline was faster than those who continued metformin in 30 to 60 eGFR. So, of course, we will use half dose, but metformin we cannot deny pleiotropic action and all that.
You want to say something? Yes.
So you told that we can start metformin and we cannot start metformin. But suppose a new onset diabetic patient comes to us. We don't evaluate first what is it it a type 1 diabetes or type 2 diabetes. In type 1, SGLT is not recommended now. So first we have to evaluate if a person does not have a family history of diabetes. We cannot start SGLT2 without confirming the patient is a type 2 or type 1. Because recent study is saying that we cannot start in type 1. Before it was saying no, we can start, it was approved. But Forxiga has launched an article that we cannot start SGLT in type 1 diabetes. If in type 2 we can start based on the family history of comorbidities, we can start. And if the patient is having a history of nephropathy in the family, in renal failure, long-standing nephropathy in the family, we cannot start. So what is the comment on that, on SGLT2?
So, as you say, that topic is next for Nilakshi maybe, that all the young patients are having type 1 or not. So that is actually the reverse topic. You are talking about type 1 in the middle-aged people. What we talk about is actually the topic for type 2. So when a patient comes to you around the age of 40, I understand that can be a LADA, but very unusually it can be only LADA and presenting so late and presenting with such a situation, and doctors as a clinician we understand how it looks like as a type 1 versus type 2. So Nilakshi will talk more about that, but again, SGLT inhibitor, there are data in favor of type 1 as well as neutrality and certain harms in type 1 as well. So again, metformin is not an absolute indication in type 1 as well. So remember that. When we talk about type 1, then metformin also does not play a role there. Remember that. So only the insulin left there. So that is a different ball game altogether. So don't talk about type 1 in a debate of type 2. So that is a different ball game, and I hope Nilakshi will elaborate the situation and how we are getting more about type 2 diabetes in this so younger ages. So again, I left the topic. Anything else from Kaushik?
No, I agree with you.
Say something for 10 seconds. 1 second, 2 seconds. Okay, so let's conclude here. And let me invite our next speaker and chairpersons.
It's time to facilitate our two speakers, Dr. Biswas and Dr. Sinha. Thank you, Chairperson.